Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent education grant from Regeneron Pharmaceuticals, Inc.
Hi, everybody. I'm Sunir Garg. I'm a retina specialist based in Philadelphia, Pennsylvania. Welcome to this program titled the Retina Futures Forum, Focus on Diabetic Eye Disease. And I'm delighted to introduce my colleague and good friend, Dr. Jenny Sun, who is spending time with us today, really learning from one of the experts in our profession. Jenny, would you be so kind as to introduce yourself?
Absolutely. Hi, Sunir. So I'm Jennifer Sun, a vitreoretinal surgeon in Boston, Massachusetts, and I specialize in clinical care and research for diabetic retinal disease. I'm looking forward to the conversation today.
Thanks. I am too. I always learn a lot from you, especially with your role as chair of the DRCR net. It's really just an amazing resource and a great opportunity to speak with you. So, our quick outline for today's program is really pretty straightforward. One is to overview our evolving treatment goals. We'll talk about a few different cases that I think all of us see every day in the office. And we'll talk a little bit about how to integrate some of these newer strategies into our day to day practice. So one of the great things about being a retina specialist is how much innovation there is. I think from the time that both Dr. Sun and I started practice to today, our laser, which was our mainstay of treatment for both diabetic edema as well as for proliferative diabetic is still used, but it has to be dusted off when we do decide to use it. And that's been a big change. And we know that with our treatments, they keep evolving. It can be hard to figure out what the best treatment option is, if there even is a best treatment option. And part of what we're going to discuss today is how we approach integrating some of our newer treatments with our previous treatments that we've had for a number of years. And we also want to talk about how kind of habits can be hard to break. I know when anti-VEGF first came out, it was kind of, well, geez, should we still do focal laser and just do anti-VEGFs for some of our tougher cases? Obviously, it took a while for the community to say, anti-VEGF is the way to go. And now with our newer agents, when do we bring them into the conversation? And how aggressively do we start to space our patients out, especially with our newer drugs potentially having an indication for a much longer treatment interval? And what's the difference between what we're comfortable with and what the patients expect from us? A lot of times those are aligned, but sometimes they're not. We'll kind of get into that as well.
You're absolutely right, Senior. I mean, we're very lucky, I think, in this field because we've got the benefit of, well-designed, large, multi-center, national and international studies that have really given us level one evidence as to how to manage many aspects of both diabetic macular edema and proliferative diabetic retinopathy. And now even studies that have looked at managing earlier stage disease like non-proliferative retinopathy. And these really go back even to the days of ETDRS and the DRS and the vitrectomy study. I think our modern era, or more modern era of medicine has really started with the advent of anti-VEGF. And it's kind of remarkable to think back now that it's been 16 years since Protocol I from DRCR Retina Network was published in 2010. And, that was the first phase 3 trial of anti-VEGF for DME. But of course, we've had many studies since then. We've certainly seen that anti-VEGF gives us better visual outcomes than macular laser alone. Across eyes, it probably gives us better visual outcomes than using intravitreal steroid, although steroid still has, I think, an adjunctive role in some eyes with DME. We've had studies such as Protocol V that have suggested that you don't necessarily have to jump to start treatment intraocularly in eyes that still have good vision despite DME. You can wait a little bit and watch. And if eyes start to lose vision, you don't lose anything by then jumping in and treating with anti-VEGF. And then we've had studies that have shown us that anti-VEGF is also a really good treatment option, similarly to panretinal photocoagulation in controlling proliferative diabetic retinopathy. And so it's clearly become first-line treatment for us across many types of vision threatening complications in diabetes. I will say, I think as ophthalmologists, it's really incumbent on us also to make sure that our patients understand the importance of systemic care and control of blood sugar, high blood pressure, cholesterol, really as a foundation of care for their ocular disease, because there's really been nothing else that's been shown to provide the degree of protection against complications and vision loss that just controlling blood sugar has. And so that continues to be really important. But it's an evolving area also with new new anti-hypoglycemics, new medications, new ways of patients monitoring their blood sugars. And I think we'll get into a lot of that as we discuss our cases today.
Alrighty, so we have a few cases teed up.
Let's focus for a moment on a scenario that illustrates how our management has changed in recent years. Sunir, can you tell me about a typical newly diagnosed patient with DME? How would you have approached treatment in the days before the next generation anti-VEGF agents were available?
It's such a great question. I'm old enough now to remember that we would set them up for a laser, and we would do focal laser, and the goal was to maybe slow down the worsening. But basically, we never saw anybody get better. And then I was around during the advent of intraocular steroids, which we thought was amazing, and then didn't seem to work that well over time. And as you know, with your involvement in the DRCR net, the longer term studies suggest that it really wasn't any better than laser, and it had side effects of IOP, rising cataract formation. And then the anti-VEGF started coming out, and the initial ones that we had with bevacizumab and ranibizumab, drugs that we still have available to us, were a huge step forward. And then when aflibercept 2 milligrams came out, we know from a lot of the data that it worked really well for a lot of patients. And we can not only stop them from getting worse, but get them better and keep them better. And some patients do amazing with those drugs. But of course, some patients just don't do as well as we hoped. And, you would take the few tools that you had and try to get the best result that you could. And many times you could get there, but other times you couldn't. The other group of patients that we always talked about is good baseline vision. What do you do if somebody had 20/25, 20/30 vision, although the OCT didn't look great? And I think we have a better sense now with the DRCR network that's been done on this, that if the vision's good and the edema is not crazy, you can sit on these patients, but we didn't know that then. And what we're seeing more recently is just not only the understanding of how important A1C control is, but that good glycemic control makes a huge difference in helping to prevent ischemia and helping the patients to protect their vision. And with our, the changes that we're seeing really society wide, not just in our diabetic patients, with being on GLP-1 inhibitors, what have you, that's a big difference that we didn't have back then. And then the other thing that's important is our diabetic patients come in a lot. I'm one of many doctors that they see, and they see me probably more often than they were ever hoping to. And having patients who are really motivated, understand the therapy, and have the ability to come in, whether it's flexibility in their job or money because of copays or somebody to help drive them back and forth. All of that can make a huge difference in their ability to adhere to treatments.
Those are all really good points, Sunir. Are there ways in which some of the newer anti-VEGF agents have changed your approach to cases of new onset DME?
Yeah, I've been using them more and more as time has gone on over the past 2 or 3 years. And the more I use it, the more I appreciate that I'm really glad I have different drugs available. For some of the newer drugs, I'm able to get patients drier quicker. I'm more comfortable with spacing them out more aggressively than I did before. And other patients who have, just some patients come in requesting the medicines because they've seen them advertised on television, what have you. And so I'm using them more and I'm really pleased with the result. The newer drugs work well for a lot of people, not everybody. Some patients either require a longer period of time or switching between drugs or still adding steroids or rarely laser back into the mix. But it's been quite helpful and I'm starting to turn to them more often than I did. But I think, some of our newer drugs do potentially hold the promises you indicated of being able to go out quite far. Aflibercept 8 milligrams, I think, just got FDA approval for Q20 week dosing. And then there's, even in the studies, there are a number of patients as they got out to week 96 were assigned to Q24 week dosing. That's not for everybody, of course, but it's helpful for patients to understand that these drugs might be really helpful to them, may give them a longer tail or time off between shots. Jenny, let's dive into a scenario that illustrates how our management of DME has evolved over time. Can you tell me about a patient with DME who was stable on treatment and how you would have approached treatment in the days before longer durability agents were available, as well as some of the challenges that you might encounter when you're taking care of such a patient?
Yeah, thanks, Anir. This is a scenario that I see very frequently. We know diabetes is a long-term chronic disease, and so it's not uncommon to see patients who do have multiple years of therapy. We know from some of the early studies, the RCR Protocol I, that over time, the burden of therapy probably decreases in patients getting anti-VEGF for DME. And yet, in the clinics, we've still got lots and lots of patients that, you know, just need more anti-VEGF or longer durations of therapy. And so it's not uncommon to see a patient perhaps, who has a multi-year treatment history, either even at the time when they step foot in my clinic or someone who I've been treating for a long time. We know that only about 50% of patients respond completely successfully to anti-VEGF from the older days and the early trials of anti-VEGF therapy, where, the retina completely dries and the vision's 20/20 or better, which means that there's about 50% of patients where, despite multiple injections, still have persistent DME and may not have perfect vision. And I think um, we're used to from again the earliest studies and the earliest medications that we had available recommending pretty frequent visits. And visual outcomes generally have been pretty good with these approaches. I think as patients that need many years of anti-VEGF, to some degree, there's a little bit of an approach of, if it's not broken, there's no need to mess with it or no need to try and fix it logic in terms of changing therapies. People kind of get a little bit stuck in a rut, I think, as we've talked about before, um, just continuing to come in and getting the same therapies over and over. And patients get comfortable with a certain drug and habitual scheduling. Um, I think that over time, though, the newer agents have given us the ability to look at some new approaches for these.
Yeah, I agree with everything you said, Jenny. I had a patient who I've been taking care of for probably 7 or 8 years, and he's in his late 50s, moderately well controlled patient with diabetes. And I had tried all of my original drugs, including some intraocular steroids, which then gave him a cataract and caused his pressure to go up. Luckily, he didn't need glaucoma surgery. And, he wasn't getting better, and his OCT was pretty ugly. Even when I had it up when I came into the room, and he'd be like, "Oh, that doesn't look so good, does it?" And then I put him on a aflibercept 8 milligrams, and I did that for maybe 4, 5, 6 shots, and he didn't budge. And I'm like, maybe I'm just been trying too hard, and maybe this is as good as your eye's capable of getting. And then much to my surprise, over the course of, like, a month, almost all of his edema went away. His vision improved, everything was happier, and I was able to start extending him out. And, whether it was coincidence, because it's an end of one, I can't say with certainty, but at least that one person in particular really stuck out at me because it was years of frequent therapy and nothing was different besides changing to one of our newer drugs. And so I think they definitely do have an important role to play for patients who are stuck in a rut, as you suggested.
Yeah. Yeah, that's really interesting. I mean, it is fascinating to me that we do see patients over a long-term anti-VEGF suddenly start to respond who have never responded before. And we don't really know the mechanisms of why that happens. As you say, also, I think having additional agents, newer agents, just gives us more tools in our armamentarium. And so I think on an individual basis, it's very reasonable to switch up therapy when you see somebody who's had long time persistent DME and you still think there's visual potential there. So I think a lot of the discussions that we have with our patients or that I have with my patients these days are, you know, are we comfortable with stability? To what degree do we want to really push aggressively to see whether a switch in therapy might optimize their results or not? Now, I will say when patients have pretty good vision, I don't push them as hard to change an agent just because we know that patients can tolerate some fairly persistent and chronic DME and maintain pretty good vision. But I do think sometimes, again, switching up to a newer agent dries out the retina a little bit better, helps with some of the fatigue of having very frequent visits, and potentially reduces risks of very high frequency injections. So, scenario, let's take a moment to think about a different scenario. To think about how our management has changed in this field. Maybe you can tell me about a patient you've seen who struggled with adherence. That's a really common problem in our patients with diabetes. How would you have approached treatment, in the early days of anti-VEGF, and how do you do it now when newer agents are available?
Yeah, this continues to be a big problem. A lot of our patients with diabetes are working age adults, and taking time off of work is a problem. And by the time that they have diabetic edema or proliferative retinopathy, they probably have kidney problems or high blood pressure or heart disease or feet problems or teeth problems or all of them. And they're going to a lot of doctors every day, and that's time off of work, it's copays, it's logistical difficulties, and heaven forbid you're not legal to drive anymore. Then you have to rely on somebody to come in and out of the office. And even in Philadelphia, where we have, a very good bus system in Center City, Philadelphia, in some of our outlying offices, there's not a great public infrastructure issue. So there's those barriers. And missed visits we know leads to potentially worse visual outcomes over time and can lead to deleterious consequences. We know from work that your leadership from the DRCR net has helped us understand is fluctuating edema probably isn't ideal for the long term. And so some of those barriers are structural and societal, and it's harder to make that better. Um, but one of the things that I used to see was, the patients did pretty well with some of our initial drugs, and they would do okay, but maybe I couldn't extend them out as quickly as I would like, or maybe I had to keep them monthly for longer than anybody was hoping for. And that's definitely a burden for patients. And anything we can do to, I think, help reduce the frequency and or get them a better visual result, or ideally both, be doing them a huge service.
So, scenario, how would you approach these patients, in today's with given today's treatment toolbox versus in older days?
So, it's still an evolving field, as the DRCRnet and your work has helped illustrate. It's a lot of work up front, and even with our newer drugs, the first 6 months or so, patients are coming in pretty often, and I'll still give them monthly doses for a handful in the beginning, trying to get them dry. And I tell them that there's two phases to treatment. There's phase one, which is to get them good, and then there's phase two, which is to keep them good and bring them in less often. And as I can start to extend out the interval, that helps not only, with their lifestyle, but with time off of work. And it also gives them some sense that there's light at the end of the tunnel. We know that that's true of a lot of our patients with diabetes, even with some of our older drugs. As time went on, they would need less frequent treatments. But at least with the data that we have available, if you look at some of the newer agents and they started doing a treat and extend type of a protocol, a lot of patients were able to get extended out quite far in between injections. Not everybody, of course, but when you can tell a patient, look, if you can work with me in the beginning, we're going to try to push you out. And there's a pretty good chance we can get you to 3, 4, 5 months apart or more. They can say, "Well, I can do that. If that's what I need to do, that's manageable for me in my life." And that's really a big deal. If there's other structural barriers that make it hard for them to come in, I do the best I can to at least understand them and help where I can as well. Jenny, for our final case, I'd like to pick your brain about a case that highlights how our management has changed for patients who would be considered high risk or high need, if you will. Can you please tell me about a patient that you've seen who you consider to be high risk, whether it's DME alone or DME with proliferative retinopathy, and or high need because their disease was perhaps just more challenging to treat, and how you would have approached treatment in the days before our longer durability agents were available?
Yeah, thanks, Nair. I think there are different ways in which you can think about patients that are high risk and high need. When I think about high risk patients, I'm probably thinking about patients with advanced
diabetic retinopathy, in particular proliferative diabetic retinopathy, with or without diabetic macular edema. Um, High need patients, I think you can think that in a couple ways. Sometimes those are patients that have challenges getting to appointments, because of transportation, because of ill health or caregiver challenges. uh, you could also think about the high need patients in terms of patients who, for professional or personal reasons, have a strong need to, preserve their vision. Not that everybody doesn't need to preserve their vision, but there are patients, photographers, or people who have, or airline pilots who where really precise visual acuity is very important to them. So of course this encompasses a wide range of patients. But I will say when I think about, kind of uh, a scenario of this, I can think of a patient of mine who had, type 1 diabetes, had only had diabetes for about 15 years, but had already advanced to high risk proliferative diabetic retinopathy. And, had some challenges with blood sugar control in the past, but was doing a good job by the time I got to know him. And this was a patient again. He was young. He was, in a professionally demanding job that had visual requirements where he really needed good vision. Also had difficulties in getting in to see us for, monthly appointments. And so that posed some challenges. And I think for us, it was really a management strategy of making sure that he had the education to understand that, A, regardless of whether he was having, visual symptoms or not, it was important to come in for regular follow up as we started the anti-VEGF treatment for his proliferative retinopathy, and he had some DME as well. Uh, it was important to help him kind of look ahead to say, look, we're going to be treating you very frequently, particularly in the first year or two of this treatment regimen, but that we will do our best to work with you to try and extend the visits or the treatment intervals when we can. And I think setting that kind of relationship where we were working on it together was helpful in encouraging him just to get in when really whenever he could.
Yeah, I think that's such an important point. I think helping patients understand, your best experience, what this journey might look like for them, I think really does help demystify what we're doing and why we're trying to do it. So, Jenny, how would you approach a patient like this today? How's your treatment approach evolved as time's gone on?
I think clearly there are a lot of things that remain the same in terms of the way we approach patients, in terms of the education and the emphasizing the importance of regular care and compliance with care. I think, here's an area, particularly for patients with proliferative diabetic retinopathy, where the potential for extended dosing is really helpful because for patients with PDR, it can be hard to get them off the injections over time, and we're much more successful in patients that have DME without proliferative retinopathy. So, so here's a patient where I might either transition a little earlier to a newer generation anti-VEGF or start with a newer generation anti-VEGF from the beginning. And then I think, all the lessons that we know as doctors about coordinating the retinal and systemic care, with the hope of preventing additional comorbidities or complications, is continues to be as important as ever. I think the kind of holistic view of the patient is particularly important in today's day where there are more medical treatments and we're seeing the advent of GLP-1 agonists and other medications that have really changed the ability of our patients to control their blood sugars much more tightly, but where we've got to be vigilant and make sure that we're monitoring them for retinopathy worsening and so forth as sometimes the blood sugars drop dramatically.
Yeah, and I'll do something similar, especially with my patients with proliferative disease and concurrent diabetic edema. I find the newer agents to be quite helpful in letting me either space people out farther if they have monotherapy, anti-VEGF monotherapy, or for a lot of these patients, I'll add some PRP in to control the proliferative component. And once I have some PRP on board, I'm then much more comfortable than, in a sense, treating the DME alone and then taking advantage of hopefully the longer durability of some of the newer agents. And then, Jenny, let's talk a little bit more about takeaways from these cases and how busy retina specialists and ophthalmologists can integrate some of these newer anti-VEGF agents into their practice?
One thing I think that's always important as you think about your diabetic patients and how you treat them, whether it's early stage disease or advanced proliferative retinopathy and DME, is that there's no one recipe for each type of condition that works for everybody. And so it really, I think what's really important is to understand kind of where the patient's eyes sits in the context of the patient as a whole. What is their glycemic control? What is their likelihood of making visits, missing visits? What's their social support like that will help them make visits if possible? And so really kind of, using all of that data in your medical decision making. So, Samir, I think as we sort of wrap up our discussion, we've touched on a number of things that, talk about how to treat specific types of cases of DME, of PDR, types of patient considerations as we think about that. I think it's always interesting to think about what changes would you make based on these conversations that we've just had, and are there routines that you would reassess? Are there patients that you would treat a little bit differently? um I guess what I would say is, for me, our conversation has really highlighted um the importance of assessing kind of what's available in the evidence, and how do we think about sort of our strategies based on a whole constellation of things. There are certain things that we're driven to in terms of step therapy and insurance requirements, but it has made me think a little bit about kind of the fact that there are a number of different considerations that go into how you treat any one patient, that include things like treatment history and previous response, and again, as we've always said, sort of patient compliance and patient overall health. I do think that it's an exciting time because, wow, this wave of anti-VEGF has changed our practice and has changed outcomes for patients across the world in ways that are just so gratifying. It's been a remarkable time to be a retina specialist and to have the privilege of caring for patients with these medications. And now that we're moving into these new generation therapies with the potential for durability, I think I'd love to see, additional studies and additional evidence as to how we use them, how they compare one head to head, and how their dosing regimens kind of affect the durability of response. Are there ways in which we can get to anti-VEGF durability that rivals that of PRP or, laser therapy and surgery and so forth? Um, so it's a wonderful time to be a retina specialist, and I think I have to express major gratitude to my colleagues that have led in this area and to our patients who have participated in the studies and who have kind of taught us so much about um, what are the things that are important to patients that affect their treatment needs and treatment algorithms. Sunir, thank you for this really great discussion.
Cool. Thanks, Jenny. It's always a pleasure speaking to you. I always learn a lot.
Sunir, thank you. This is really great. And I will thank the audience as well. Thank you for participating in this activity. We'll ask you to please continue on to answer the questions that follow and complete the evaluation.